So we are joined by Dr. Jennifer Cooke. Dr. Cooke qualified in the year 2000 from Southampton University Medical School, and after postgraduate psychiatric training at Guy's, King's, and St Thomas's, has been practicing as a consultant psychiatrist working in the NHS in Brighton and Sussex since 2012. After working on an acute female inpatient unit in Sussex for 2 years, Dr. Cooke was involved in developing perinatal mental health services across the country and has been a consultant perinatal psychiatrist and clinical lead for the Sussex Partnership Specialist Perinatal Mental Health Service since 2016. Dr. Cooke has a strong interest in education and training, both at Brighton and Sussex Medical School and for the Royal College of Psychiatrists. She is an honorary assistant professor at BSMS, involved in undergraduate interviews and clinical training for third and fifth year medical students. She is also the faculty lead for the Sussex Perinatal Mental Health Simulation Training course. So Jennifer, thank you so much for being with us tonight, and I will hand over to you.
Thank you so much, Agatha, and welcome everybody. And nice to see so many of you here, although I can't actually see you. So it always feels a bit strange just talking to a blank screen, but I know that you're all there. So I'm going to talk to you tonight about my job as a perinatal psychiatrist, and explain a bit about what that involves and why I do it and why I like it. And also talk a little bit about becoming a psychiatrist and my journey into what I do now, and perhaps then think a little bit with you about your journey and how to get that started. So I've talked a bit about this already, but I've told you who I am. Agatha's told you who I am in detail. I guess I want to be clear in explaining, what psychiatry is in general, and then what perinatal psychiatry is. And hopefully, I will sort of clarify anything that you're not sure about as we go along, in terms of the type of job that I do and my journey. I was going to say about questions. We will have lots of time for questions at the end. So sorry that I can't answer your questions as we go along. But yeah, if you put them in the chat, and then we'll get to all of them towards the end. So just to start with, before we get into things, I did want to know a little bit, because I can't see you all. If you wouldn't mind all taking out your phones, it's the only time I'd ask you to do that this evening, and go to mentimeter.com. You should be able to use that QR code to get there as well. And I'm hoping this will work for me to find out a bit about you as an audience and who I'm talking to. So Oh, good. I can see people are doing it already, so it is working. I just wanted to understand a bit about who you are, how old you are. So I can see most of you are that 16 to 18 age bracket. And I guess that means that you're at college, and that you're in the process of thinking about applying to medical school, and thinking that you'll be doing that in the near future, or you might have already done it. Great, that is super helpful. And we've even got two people in the 14 to 16 age bracket. So welcome to you guys, super keen, that's brilliant. Okay, I'm going to go to the next slide, and a few older people as well, that's great. I'd like to know a little bit about where you all are. So could you just tell me where you live or where you are now? Wow, okay, all over the place. For some reason, I was sort of thinking most people would be in Brighton, but not at all. Right, so that's fantastic. London, Oxford, sorry, all over the place. Athens, wow, Australia. Wow, brilliant. This is much much wider ranging than I thought. Singapore, we've got there. Goodness me. Okay, so people from all over the place. That's brilliant, and really nice for me to imagine you all there in these exotic places. Okay, I think that is all we're going to be doing for now. Actually, no, one more slide. I want to ask you before we get going. So, what area of medicine are you interested in as a career? Right, so that's a good spread, isn't it? Lots of surgeries, lots of psychiatry. Brilliant. Well, I guess that's why you've joined this evening, which is fantastic. Three of you don't want to be a doctor. Okay, that's fine. That's fine too. GPs, general medicine, not so popular, and a few not sures, which is absolutely to be expected at this stage. Surgery, very popular there. Fantastic. Good. Well, that really helps me to understand a little bit about who I'm talking to. Um, Super. So on that note, we will go back to my presentation if I can get there. Yeah. Okay. So let's just talk a bit about what is psychiatry, because I do think it's not necessarily clear in everyone's minds when they first start medical school. There's a lot of confusion between psychiatry and psychology, I think. So just to be clear, psychiatrists are medical doctors, and that is a very different training pathway to becoming a clinical psychologist, whereby you would study psychology at university and then go on postgraduate study as a clinical psychologist. So, psychiatrists are medical doctors who focus on the treatment of mental illness, tending to use a biopsychosocial sort of medical model to diagnose and treat mental illness. Because we're medical doctors, we can use biological interventions. So we might use blood tests or brain scans to investigate our patients. We might use physical examination techniques, and we can prescribe medications. And that's something that a psychologist, for example, wouldn't be able to do. As psychiatrists, many of us have gone on to do extra training in specific modalities of talking therapy. So we may have done a training in CBT or cognitive analytic therapy, for example. So we may be able to practice specific talking therapies, but not all psychiatrists will do that. So not all psychiatrists will be therapists as such, but many of us have done those additional qualifications. And, the biopsychosocial model would include more sociological interventions, such as thinking about lifestyle factors and social prescribing and thinking about, general sort of advice around nutrition or just healthy living. So, and we would work as a part of a big team who would also be involved in sort of facilitating the various different interventions that we might recommend. So our multidisciplinary teams, MDTs, you've probably heard of that term, but as psychiatrists, we work in a team, and that team will include nurses and occupational therapists and maybe social workers, maybe sort of support workers, nursery nurses that I work with. And that's really fundamentally important to the delivery of care in psychiatry, as it is in many other medical specialties too. What is perinatal psychiatry? So this is the area of psychiatry that I practice in, and I'll talk a bit more about that later on in the talk. So peri comes from the Greek meaning around, and natal confusingly comes from the Latin, which means birth. So perinatal means around the time of birth. Perinatal psychiatrists treat women and birthing people in pregnancy and up to 1 year postnatally. So that is the period that I'm talking about when I talk about perinatal psychiatry. And it's unique as a field of psychiatry in that we're treating both mother and baby as a dyad. When you consider a pregnant woman or a postnatal woman, you need to consider the context of the pregnancy and the fact that there's a baby present, and that changes the way that we assess and treat patients, and that's why we're different to other psychiatric specialties. We work really closely with obstetricians and midwives, paediatricians, neonatologists, and children's social care. So we really have a very sort of close working relationship. We run clinics together. We're situated in the same building as the obstetricians. And that's quite different to many other sort of psychiatric specialty doctors who will be quite separate, really, to a lot of the acute sort of physical health care providers. So why is it important to think about treating mental health in the perinatal period specifically? Well, it's not new. I think for many, many years, people have known and understood that the woman's state of mind during pregnancy is important, and it may have some effects on her developing baby and the child once it's born. I like this poster from the National Child Welfare Association of 1919. Don't listen to old wives' tales. No shock can mark an unborn baby. No horror sight can deform him. But worry, anger, and fear may affect his mother's blood, which supplies his food. So she should be calm, happy, and sweet-tempered. So people have known for a long time that it is important to think about mental health in pregnancy. More recently, in this country particularly, we have had things called the confidential inquiries into maternal deaths. And that is where, in some detail, every 3 years, a panel of experts look into all cause of maternal death in the UK and try to understand the causes and think about what we could be doing, policy and services to try to prevent mums from dying, essentially. And quite a lot of helpful information has come out of those inquiries. From those, we've learned that suicide is one of the leading causes of maternal death in the UK. This is quite an interesting pie chart to look at, and it shows all causes of maternal death in the UK in the period 2018 to 2020. It surprises a lot of people that suicide and drug and alcohol and other psychiatric causes account for the vast majority of maternal deaths in the UK, much more so than any other causes, cardiac malignancy, thromboembolic causes. So, I think as a result of these inquiries, it's really made people sit up and think, why are so many mums dying from mental health and suicide related problems? The overall numbers are small, by the way, but, proportionally, this is a huge proportion. So it's really made people think, hang on, we should be doing something better. This shouldn't be the case. What are we doing wrong? Why are we not providing psychiatric care better to mums in this important period? There's been various studies and reports done over the last few years, and this particular one done by the Centre of Mental Health and LSE in 2014 was really revolutionary in that it showed that poor maternal mental health in the perinatal period has negative impacts on the development of the child, emotional, social, psychological and social, and also on the wider family, and also a huge cost to society in terms of public sector funding, health and social care. So, this really, again, made people sit up and think, hang on, we need to be getting this right. Why we should be improving services. During the last Conservative government, so 2017, 18, 19, they commissioned a couple of reports, the first one being the first 1,000 days of life, and that was written by the House of Commons Health and Social Care Committee, and it essentially examined what was going on for families during the period of conception up till age 2. And it concluded that their environment during these periods and the care that they receive and what happens to them in this sort of formative period really does shape their physical, cognitive, social, emotional development for life. And the adverse experiences during that period really have a lasting negative effect. And adverse experiences would include parental mental ill health or substance misuse and poverty. So these reports essentially highlighted this and started to make some suggestions about what we needed to do policy-wise and service-wise to improve things for parents and their babies in terms of long-term outcomes. I don't know if how many of you have heard of Donald Winnicott. He was a famous pediatrician and a psychoanalyst in the sort of 50s, 60s, who did a lot of work on sort of parent-infant psychotherapy and thinking about what made for a happy baby and a secure baby, and what conditions needed to be in place for mum to particularly to be able to provide that care, and how important it is always to consider a new mum and a baby together. Right, so I could talk about this all day, but essentially I'm trying to provide some background as to why we need to focus on mental health in the perinatal period. So I think I've made the case. So let's think about what actually do we do? What can we do to try to improve things? So actually at this point, let's go back to the Mentimeter. And imagine that you're someone with a history of mental health problems who's recently found out they're pregnant. What might be worrying you? Where are we? Sorry. So what might be worrying you? If you are a pregnant person with a history of mental health problems and you've just found out that you're going to have a baby. So I've got whether I have the ability to be a good parent. Absolutely. And that's probably a worry that's shared by any person that's just found out that they're pregnant. So whether it could be a genetic condition and my baby could carry it, being a good enough parent, passing on the mental illness, absolutely, to the child. Can I look after them? Capability. Could I hurt my baby by accident? Absolutely. Might I not be able to look after my baby and provide comfort and support? So absolutely, there's all sorts here, aren't there? Anxiety of financial support, um, relapsing and how that could affect the baby. Can you look after the baby when you're suffering yourself? If I can take care of the baby to the best of my abilities, um, do I deserve the child? Absolutely. So lots of anxieties about being able to cope with your own mental illness, looking after the baby. What if the baby's affected? What if I relapse? Impact on other children. So many worries, aren't there? So many worries and concerns which are really valid, and some of them are universal, I think, to perhaps anyone who finds out they're pregnant, and some of them are quite specific to people who are going through a pregnancy with a mental illness. So a lot of these people have said, and thank you for those brilliant responses there. They were really insightful and really good. I think interestingly, not many people mention stigma, and I, partly I think that is because there is a bit more of a shift in society these days away from mental illness being so stigmatized, which is brilliant. But I think that stigma is still there, and as well as all the things that you all suggested there, I think I often hear from women real worries that if I talk about the fact that I have had this mental illness in the past or that I'm currently depressed, I won't be allowed to keep my baby. And social services will come along and say that I should give it up or they should take it away. So, that's a massive concern. And that's sometimes a reason that people don't want to share information, which actually, if they did share, could help them to get what they need in terms of support and help. So, as you can see, a whole host of different issues that may go through the mind. So just to talk a little bit about the team that I work in and the kind of work that we do with patients. We are the Sussex Specialist Perinatal Mental Health Service. We cover the whole of Sussex in 4 different teams. I wish this was our building, but it's not. AI just generated it for me. But we do have team bases in the 4 different areas of Sussex, but they don't look as nice as this. In the teams, we have consultant psychiatrists. We have resident doctors, and those include core psychiatry trainees and higher trainees in psychiatry. And I'll explain a bit more about what those are later on. GP trainees. We have a team leader in Brighton. Our team leader is actually an occupational therapist by background. We have nurse practitioners. We have specialist psychiatric nurses. We have psychological therapists and psychologists. And we have early years workers who do kind of practical support with women. And we have admin. So who do we actually see? Most people would be referred into our team by their midwives or by their GP when they first find out they're pregnant. And we see people who are during pregnancy or up to 1 year postnatal currently struggling with their mental health, or they might be pregnant and actually okay at the moment, but in the past they may have suffered from a severe mental health problem, like a bipolar disorder, for example, or they might have had a previous psychotic episode. So we see that group too. We see any woman who's had a previous postpartum psychosis, which is a very severe form of mental illness that can happen immediately after you have a baby, where you become very distanced from reality. And that can be a very sort of quite a severe, risky sort of crisis presentation. So anyone where that's happened to them before when they've had a baby, if they get pregnant again, there's around a 50% chance it would happen again. So we would need to see those people again. And we also see people with a lot of complexity. So they may have substance misuse problems, they may have comorbid severe neurodiversity, complex trauma in their background. We see people who have a real fear of childbirth. That's called primary tocophobia, and that's a fear of childbirth when you've never had a baby before. And obviously, everyone has some kind of fear of childbirth. Nobody looks forward to it, but I think most people accept it's something that they might need to go through at some point. But for some people, they're absolutely terrified and put off having a baby, or in fact, decide to never have a baby because they're so fearful of it. So we work with that group too. We offer preconception counselling, and that's so we see people for as a one-off appointment before they get pregnant who may want to just think about planning a pregnancy if they have a history of a severe mental health problem. And we also see people who have experienced a neonatal loss or a stillbirth, because obviously that in itself is a huge trauma. So what do? Well, we work together, as I said, with lots of other health professionals across the perinatal care pathway to provide assessment and treatment and support for women and birthing people during that pregnancy or up to 1 year postnatal. We run clinics in local children's centres and in antenatal departments. We go and see people at home, and sometimes we see people in hospital. If our patients need to come into a hospital, we arrange for them to come into a psychiatric mother and baby unit. And that's essentially a mental health unit where women come in with their babies, and it's staffed by specialist nurses and nursery nurses as well as psychiatrists. So that would be where we treat perhaps the most severely unwell people after they've had their baby or in late pregnancy. We use medication, we use psychological therapy, we run groups, we do practical work, we work, in a sort of variety of different ways, really, with women to support them, as well as with women in hospital, if needs be. And our nursery nurses are so helpful, I think, for us in our team, in that they're brilliant. They visit people at home, help to work with them, building confidence with their babies, getting out to a mother and baby group, learning how to play with your baby when you're not sure, when you're very depressed or very anxious. People can find that very difficult. Just things that would be intuitive to most people. Just responding to a baby when they smile or knowing how to talk to them. That sort of really practical work can be super helpful for some of the women that we look after. So to give you a better idea, actually, of how we work and what we do, I would like to show you this video, if I can. Okay, I might need to see if this works.
Moments were overshadowed by nothingness, guilt, hopelessness, and doubt. Just that feeling that I was failing and that I couldn't cope. I felt out of control. Eventually, I plucked up the courage to talk to my midwife. When week 4 hit, my mood was dipping every day at 8 p.m. I couldn't cope with the sleep deprivation. I just wasn't expecting it. No one talks about how difficult it is. A deep black hole used to open up inside me every time my baby cried. I didn't know what to do, and I found that I was desperate for him to stop. I didn't seem to be able to feed him, comfort him, respond to him, or even know what he wanted. It was when I spoke to my GP, I found help. I remember looking at him and thinking, my marriage won't survive this. I'm a terrible mum. The baby hates me. I've ruined everything. I couldn't see a future for us. It was my shameful secret that I wasn't able to love my baby. My biggest fear was if I admitted what was in my head, he would be taken away from me. Despair and desperation just took over. On my darkest days, I stood in the shower, crying, thinking about how I could end it, how I could end my life. Eventually, I spoke to my health visitor, and they referred me to the Sussex and East Surrey Perinatal Mental Health Service. I didn't need to tell my story more than once. After I got referred, I didn't really need to do anything. I just got the help I needed. I remember turning up at the appointment with the psychiatrist, feeling terrified. But when I met her at the local children's centre, it was amazing. She was extremely kind and patient and reassured me I'd get better. She invited me to bring my partner to the next appointment if I wanted, and suggested regular home visits from one of the perinatal nurses and weekly psychology sessions. So there's support for me and also support for my partner. In Sussex, the team understand that everyone is different. Working together, they helped me co-design a care plan that worked for me, that we changed over time as and when we needed to. The care involves a lot of different things. One of the perinatal nurses visited me at home and helped me get baby-safe medication. Every Friday morning for about a year, me and my baby went to parent-infant psychotherapy. It sounds very formal, but it's really just that we had a safe place where we could both go, a place where I had no walls up, none of my safeguards in place. I received complete non-judgmental help and support. Just getting that, knowing it was there, that was the start of my recovery. It wasn't threatening. No one wanted to take my baby away. No one was mean to me. To anyone suffering like I did, I would say this. At the Perinatal Mental Health Service, You will find very skilled help from a team of highly trained professionals working behind the scenes and on a one-to-one basis to make things okay again. And each one of them knew and understood what I was going through. I have an amazing bond with my son now. I feel like things are much more as they should be.
It's like I've got myself back, but also I have this amazing gift. I love my little girl, and I'm so thankful that I found the help that I needed.
If you have related to these stories, or you know someone who might, please encourage them to tell their story to someone who can put them in touch with us. Because we understand. Because some of us have even been through it ourselves. We're here and we're ready to help.
Okay, I'm going to just stop this and then restart it to get back to the presentation, if that's okay. Okay, so that video was made by our perinatal service to explain what we do, but I wanted to show it to you because I think it uses the women who have experienced perinatal mental health problems themselves to tell their story, which I think is quite powerful and important for people to hear. So I've told you about our service and what we do, and the kinds of people that we work with. I thought I would talk a little bit about my journey to becoming a perinatal psychiatrist, and perhaps then go on to talk a bit more about what you could do if you are interested in following that sort of route. So I was at medical school in Southampton, as Agatha mentioned in the beginning. And all the way through my medical school years, I always really enjoyed my psychiatry placements. I always just thought that understanding the brain and disorders of the brain just seemed more interesting than any other sort of specialty area or organ. I remember having a good experience on placements in psychiatry. To be honest, I enjoyed quite a lot of my placements in medical school. There wasn't many that I disliked. And I think it's hard when you go through med school and you like lots of things. It's difficult to choose. But I think the mentors, the teachers that you have as a student do affect you. You do look at the people around you and think, I can see that they enjoy their job and they're passionate about it, and that is something that I aspire to. So I think that made a difference to me and some of the teachers I had at medical school and as a trainee as well. I definitely like the idea that in psychiatry, the doctors tended to have more time to spend with patients, and they were able to gain much more full understanding of the patient's problems. It wasn't just isolated to one, a problem with my foot, or I've got a some kind of infectious disease, or you really spent time trying to understand everything about a person and their life and what had happened to them up till now. And I just like that slightly more holistic sort of way of working with people. As a trainee, or what we now say resident doctor, the psychiatric training programs were really good. And as a trainee, you were allowed time to develop your special interests in terms of research or teaching, had good supervision and support, and that was important to me. And then having qualified as a consultant, I was attracted to working in perinatal psychiatry because it was a fairly new developing area, actually. I initially worked, I had an interest in women's mental health. I worked on a female inpatient ward, and over the course of that, I had some patients who were pregnant and postnatal, and just felt that it was a period that was massively overlooked in terms of specialist provision, and such an important time to get it right in terms of treating mental ill health. I think it's the one area of psychiatry really where you can really predict who the high risk patients are, patients with a pre-existing bipolar disorder or postpartum psychosis, and when they're going to have their baby, and when the high risk times are, and that's quite unusual, I think, in mental health. And I like the fact that psychiatry and perinatal psychiatry are real team working specialties, and that you work with colleagues from not just within psychiatry, but from a whole many other sort of healthcare professionals, as I've mentioned before, and that appealed to me. So that's why I chose to do what I ended up doing. And the pathway that I took would be similar to the ones that you may take if you choose to apply to medical school and want to become a consultant. So as you all know, Medical school is usually 5 years, depending on if you enter as a graduate or undergraduate. You finish your med school training, you then do 2 years in the foundation training school, and you would rotate around various different specialties during that time, including medicine and surgery. In my day, because I'm quite old, instead of foundation training, we did a house job. So I spent 1 year doing house jobs, and that was 6 months medicine, 6 months surgery. And after you finish that year, you're then properly qualified and registered as a doctor. You then could choose to go into core training in the specialty area that you want to pursue. Actually, at the end of my foundation training or house job training, I wasn't quite sure what I wanted to do. I thought I wanted to do psychiatry, but as I've said, I really enjoyed so many different parts of my training that I actually did A&E. So I went to work in accident emergency for a year in Portsmouth. And really enjoyed that. I really liked emergency medicine. I liked the sort of pace of it. I liked the fact that anything could come through the door, lots of drama, emergencies. And I really enjoyed that year. But at the end of that year, I remember thinking, actually, the cases I really get interested in and the patients I really want to know more about are the mental health ones, the psychiatry patients. And I decided that I would pursue a career in psychiatry. So then I went to applied for core training on the Guy's, King's and St Thomas's training scheme, as it was at the time. And that's a 3-year training scheme where you rotate through various different specialties within psychiatry. So as you can see, there's a huge number of different specialties within psychiatry. So adult psychiatry, substance abuse psychiatry, old age psychiatry, child psychiatry, perinatal, youth psychiatry, which is focusing usually on sort of teenage years. There's crisis teams which work with people in the community through acute periods of crisis. Liaison psychiatry, which is working in the general hospital and the acute hospital with patients who are admitted to other medical specialty areas presenting with mental health problems. Forensic psychiatry, so people in the criminal justice system, in prisons, who are presenting with mental health problems. So huge number of different specialties within psychiatry itself. During those core training years, you do your postgraduate psychiatric exam. So that's your membership of the Royal College of Psychiatrists exams. And there's in psychiatry, there's 3 exams: paper A, paper B, and what's called the CASC. Paper A and B are multi-choice papers focusing on different clinical topic areas. And the CASC is a massive OSCE, essentially, that you take towards the end of your core training. And it's probably the most intense OSCE that you'll ever take, with actors playing the parts of their patients. That's quite a hardcore one. After you pass that, you can then enter higher training in psychiatry, which is 3 or 4 years, depending on what you do. And that is where you can specialize even more. So you can choose to focus on old age psychiatry or general adult psychiatry, which would include perinatal, or you could do child psychiatry, or you can do medical psychotherapy, where you do much more of an in-depth psychotherapy training, or you can do forensic. So those are the areas that you can choose, or you can choose a combination of those in some cases. And at the end of your higher training, that's when you get your certificate of completion of training, or CCT, and then you can become a consultant. So during core training, that's what used to be known as an SHO years. Higher training, you're a specialist registrar, and then consultant after that. So that's the pathway. So you guys I remember from the beginning, from the Mentimeter, are mostly probably at college thinking of applying to medical school. So I thought I might say a little bit about the kinds of things that you could be doing now if you are interested in pursuing a career in medicine, and what could help you to sort of get on that ladder. So first thing, A-levels. Probably most of you are doing A-levels. I know that there are other qualifications you might be doing, such as IB, or there are other qualifications that you may be doing if you're abroad. I'll talk about A-levels here because that's what I know about, but I do appreciate there are other things. Most medical schools would expect you to have done chemistry A-level, but not all. So there are some medical schools where chemistry is not an essential A-level. I think biology, again, is a sensible and helpful choice if you're applying to medical school, but again, it's not essential in all medical schools. They don't require you to have it. Most medical schools, in fact, all medical schools require you to have done 3 A levels. And it does vary school by school as to what the requirements are. I mean, personally, I think biology and chemistry are probably a good bet. A third one, maths can be useful and helpful, but really only if you're good at it, because not everyone has that sort of maths brain, and it's not an essential requirement. So if you're not very good at it or you hate it, it's probably best to not do it, I'd say. A third A level could be physics, economics, sociology, psychology, all of those, you could see their use. And many medical schools will accept a humanity as a third A level as well. But I would say when you're making these choices or thinking about it, check the med school requirements, because each med school will have a different requirement. And there is some helpful information online about that. I think the Medical Schools Council has some really useful resources there. They've got a collection of all the different med schools and the different entry requirements that are needed. So another really important thing to be doing during your college years is some work experience. Because when you're applying to med school, when you're writing your applications, your personal statements on your UCAS forms, and when you are invited to interview, you will need to have something to talk about as to why you want to do medicine, and what you have done to kind of give yourself some experience in the kinds of areas that are important in being a doctor. And so work experience, ideally in a healthcare setting, and that could be in your local hospital. Most health trusts so that would be in the UK, have work experience programs that you can sign up for. And you just need to go on the hospital website and say, for example, in Brighton, Sussex Partnership is the trust I work for. I think I should be able to show you here, actually. I did try to... oh gosh, it's disappeared. Right, never mind. I'll go back to this slide. So if you just Google Sussex Partnership Work Experience, for example, it'll come up on the page, and you can register for work experience, and you fill in a form and you say which area you want to do work experience in, and they match you up. So it used to be so much about, has your dad got a friend or your mum, who's a doctor, and can they get you in somewhere to do some work experience? I think we're really trying to move away from that, and work experience should be open to everybody, and it shouldn't depend on who you know or who your parents know and who they can set you up with. And one of the things I do some of the interviews for the med school, and one of the questions that I like to ask is, how did you organise your work experience? Because I'm much more impressed by somebody who's done that themselves, sent in a CV to a local care home and gone and done some volunteering or some work there, or they've gone online and found out about the work experience at a local hospital themselves and done that. I think that shows a lot about your sort of enthusiasm and passion and ability to kind of organise things yourself. So I think trying to get some kind of healthcare-based work experience yourself is a great thing to do. I think doing some volunteering is also a brilliant way of getting some skills and experience in leadership and working as part of a team, and just developing your confidence really in working with other people. And it also shows some that you're sort of committed to trying to sort of help others and do something good. And that doesn't need to be necessarily in a healthcare setting. That could be coaching a sports team, or working in a school, or working with children in a play scheme or something like that. It doesn't need to be anything sort of clever and doctor related. It just needs to be something that's working with people and showing those skills. So those are all brilliant things to try to do in preparation. And I think another thing is just reading, being curious about what's going on in the world relating to health. So looking at the BBC News site, looking at medical journals if you have access to those, following perhaps people on social media, prominent doctors or medics, or people that you might be interested in, so that you just show that you're a bit curious and interested in what's going on and developing in the world of medicine. So there's a few little tips and hints for you, things that you could be doing now. I put some useful links and things here, which I think you might be able to get these slides afterwards and have a little look more for yourself. So that is me really. That's the end. I've got some time for questions, but hopefully what I've done today is talk to you a bit more about the field that I work in and helped you to understand what we do as perinatal psychiatrists and why we do it. And that I've helped you to understand how you get to be a psychiatrist and what that pathway looks like, and what the opportunities are within psychiatry. And then finally, just giving you a few ideas about what you could be doing now to prepare for either applying to medical school or having an interview, and taking your career forward. Okay, that is the end. So I'll hand back to Agatha.
Thank you so much, Jennifer. I found your talk so insightful and interesting. You know, perinatal mental health is not a specialty that I'd really heard about much before. So it was really fascinating to kind of hear about what it actually is and why it's so important. So thank you so much for that. And you've actually anticipated some of the questions in the chat already, because some people were asking about kind of work experience and experiences and skills they might want to gain for applying to medical school. So that is brilliant too. So let's kick off with some of these questions then. So we have a question from Sarah, which is, what does a typical week look like for you in this role?
That's a good question. So I guess not every week is the same. That's the first thing to say, because I have lots of different parts to my job. So I have my job as the clinical psychiatrist in the perinatal team. I also do work for the Royal College of Psychiatrists, running exams, and I also act as I'm the sort of professional lead psychiatrist for the perinatal team. So I'm a sort of manager to some extent as well within the service. But just as a rough idea, Mondays I tend to have more as a sort of management / meeting day. So I do things like I might supervise my trainee. So I would meet with them for an hour to talk about what they've been up to, cases that they need help with, their sort of career development, that sort of thing. I might go to our service leadership meeting. So I'd meet with our service manager and our lead nurse to talk about how our service is working. Are we seeing the right numbers of patients? And are we, doing what we need to be doing? Are there any problems? How are we doing with staffing? Do we need to recruit anyone else? That sort of thing. And then I perhaps would do some preparation for any teaching that I have planned or that sort of thing. So sort of more of a planning, management-y kind of meeting day. Tuesdays is a real clinical day. So I run a clinic at a children's centre, which is a postnatal clinic. So that I see women who have had their babies in the last few months or recently. And I'd usually see 5 or 6 patients that morning. Then I go over to have a big meeting with all of our team, and we talk about all the new cases that have been referred to our team that week, and we talk about any patients who we think we're worried about, or we have concerns that they might be getting unwell. So that's Tuesdays. Wednesdays, I do a bit of a mixture of things. So I often do some home visits to patients at home. And then in the afternoon, I do some teaching usually. And I also attend a sort of supervision group myself with some other perinatal psychiatrists who are clinical leads in their own services. So that's quite helpful for me in my own sort of support and development. We meet regularly to do that sort of peer group supervision, we call it. Thursdays, I do a joint clinic with one of the obstetricians. So we go in the antenatal department and we see patients together who have sort of obstetric complexity as well as psychiatric complexity. So that's our Thursdays usually. And then Fridays, I usually, varied really. Sometimes I go up to the Royal College and to do some work on the exams. Sometimes I would do more sort of local kind of work, but I tend to not see patients on a Friday, and I only work Friday morning, and Friday afternoon I have the afternoon to do other stuff usually. I've got 3 kids, so usually something relating to them often, and that's my week.
Wow, it sounds like a busy and very varied week. Yeah, wow, up to lots of different things.
Yeah.
Brilliant, thank you. Let's see what other questions are popular. we've kind of done that. Um, um, Dia has asked, what was the transition like from graduating from medical school to your foundation training?
Yeah, that's a good question. I think it's much better now than it was when I graduated. I graduated in the year 2000. And at the time we went into our house jobs. That's what it was called. We did the 1 year house job year and 6 months medicine, 6 months surgery. So I started as 6 months surgery and I was working in a really busy hospital on a liver unit where people had had like liver transplants and like really complicated abdominal surgery. And at the time, it was before everyone got sensible about junior doctors' hours and things. And we were working ridiculous hours. I mean, I could go on about this for a long time, but we used to regularly do 90-hour weeks or something. We'd start our on-calls on a Friday morning and we wouldn't go home until Sunday afternoon. It was ridiculous. So I don't, I mean, obviously it was horrendous. It's really not like that now. And we learned a lot. And actually I did enjoy it. I had a great time. I had great fun. It was brilliant to finally be a doctor after all that studying and not to be a student anymore felt great. And I worked with brilliant people. And actually, even though it was hard, I definitely got so much out of it. And I think what they've done over these last 20 years or 25 years is just to realize that for people who have just qualified going into their first job, a lot more support's needed and it's managed a lot better and the hours are much more sensible and the supervision and support's much better. So I think it's always going to be a shock when you finish being a student and start being a doctor, but you're really ready for it, I'd say. You've been a student for such a long time and you can't wait, I think, to actually start practicing. And even though it can be a bit stressful and the hours can be, long and you can be doing things that are a bit scary sometimes, I think overall you're so happy to have finally got there and to not be a student anymore that it's a positive experience.
Yeah, absolutely. I think you're, yeah, like you say, you're just probably really ready
Yeah.
to go out and do it, aren't you, by the time
Yeah.
you get there? And I know, exactly as you say, in terms of support and things at BSMS, there's the F0 module that's been introduced, which is, for the audience, your foundation year is often referred to as F1 and F2. So at BSMS, we do the F0 to kind of try and help bridging that gap as well.
Yeah,
Absolutely.
absolutely. It's much better managed than it was in my day. I remember my first day on the ward suddenly realizing that no one had really taught us how to prescribe any medications. So we knew what medications you roughly needed to treat a condition, but no one had ever said, well, when you write it on a prescription, you have to write it like this, and it's this many milligrams, this many times a day, and like antibiotics or pain relief. And we were all like, oh, we don't actually know how to how to do that. And we had to get one of the SHOs to come and just write us out a big sheet of how to do it all. I
Oh,
mean, it's stuff like
wow.
that, which you think, my goodness, how did they neglect to teach us that for the whole of medical
Yeah.
school? But anyway, I thought it's much better now.
Oh yeah, but I guess knowing that you can ask for help, right? Like in that
Yeah,
situation, there's someone who will be able to write you a cheat
absolutely.
sheet or whatever. Yeah.
Absolutely.
A question from Thea is: do you have any certain any kind of methods or ways that you use to approach women or pregnant people or birthing people who suffer from mental health issues?
Um, I suppose there isn't maybe one answer to that, and I think it would vary so much on the person and the circumstances. I think definitely just that awareness of how difficult it can be for people to talk about their mental health. And for many people, they may not have really spoken about it before. So sensitivity and sort of not pushing people too much initially, trying to explain to people why you're asking them the questions. So why it might be important to speak about it, because what we can do to help, and actually the fact that leaving things unspoken about or untreated can in itself lead to adverse consequences. So trying to explain the rationale or the reason that you're asking can be helpful. Um, and trying to explain that we're, what the help might be that we can put in. Um, Trying to allay people's fears really about talking
Mm.
about their problems. Um, Yeah, so just sort of a gentle approach, and but also not being afraid to ask. Because I think one of the things, I do lots of training with midwives about talking about mental health problems, because obviously the
Yeah.
midwives are the people that see everybody, and the midwives need to work out who they might need to refer to our service. So they
Mm.
do need to ask people, well, do you have any problems with your mental health? And have you ever struggled in the past? And I think some midwives can be very afraid of doing that because they haven't really had the right training on mental health. And there's something about how you ask the question. So it used to be on the booking form that the midwives completed with all the patients, there was one little box and it just said mental health, yes or no. And the midwives didn't really like asking it, so they just say things like, "Oh, you don't have any mental health problems, do you?" And of course, your immediate answer to that will be, "Oh, no, no, no." Whereas actually, we've done some training for them to say, how have you been feeling in the last week? Have you struggled at all with anxiety? Do you ever struggle to feel positive in your mood? Just some more specific questions, and asked in a better way can make a big difference, I think.
Yeah, that's really important to think about. Yeah, the framing, I guess, of those kind of questions
Yeah,
and conversations.
yeah.
Um, a question from Carolina. Carolina says they are conflicted between wanting to study neurology or psychiatry. What would you say are the main differences, and what would you say made psychiatry your preferred specialty?
Mm. Yeah, I mean they're very closely linked, neurology and psychiatry, and there are sort of crossover areas. So neuropsychiatry is a specialism
Mm,
within psychiatry, which kind of draws together um, neurology and psychiatry. So we'll focus more on, for example, psychiatric illness or mental illness as a result of brain injury, um, and yeah, neuropsychiatrists and neurologists work very closely together. Um, I suppose I was more drawn to psychiatry because I think the the sort of finding out more about people's lives and their stories and their experiences just felt more of interest to me. And I suppose
mm,
neurology felt that it's much more of a sort of medical specialty, really, with a basis in a sort of a very strong sort of ties to anatomy and neurophysiology and interesting, but a very different area of focus. And yeah, for me, it just didn't quite hold the same sort of interest and fascination. But I do think the two are closely related, and there are certainly areas within psychiatry that link very closely with neurology, but they're
mm.
quite different as specialties, I'd say.
Okay, that's interesting. Maybe Carolina, maybe neuropsychiatry might be for you then. um, Victoria has asked, are there any specific books that you might recommend for people who are in college who might be interested in psychiatry?
Hmm, that is a good question. I mean, there's probably loads. Um, I think there's I think famous books. I don't know if you've heard of Oliver Sacks, who's a famous neurologist
Mm,
who wrote a book called The Man Who Mistook His Wife for a Hat. That is a fascinating book that sort of explores various. I mean, that's probably more neurological, actually, I suppose, in its focus. But I think that is a good crossover between neurology and psychiatry, and it talks about different brain injuries and the sort of psychiatric and neurological impacts. But he's a very good writer, and it's very entertaining to read. So that's a good one. Um, I think. There's yeah, I'm just trying to remember the title. There's various there's a book by an author called Bryony Gordon who's very entertaining and funny, and it's called Mad Girl, and it's about her experiences of having obsessive compulsive disorder, OCD. And she in it talks about going through a pregnancy as well. And I think that's a good sort of it's
mm,
autobiographical, but quite sort of humorous as well. So that's probably a
yeah.
lighter read, but I think that could be something that would be interesting for people to read. The one I think it's called something like Motherhood and Madness, by a woman who has a history of postpartum psychosis in her family. Um, and that's another interesting. It's slightly fictionalized, I think, but again, good portrait of what postpartum psychosis looks like. I may have got the title wrong though, so yeah, but I think you could probably Google it.
Yeah, I'm sure. Brilliant. Thank you, Jennifer. Hayat has asked, what is a part of your job that motivates you?
That's interesting, isn't it? I think different things on different days. I think I really like the variety in my job. I like the fact that I do clinical work, but I also do teaching, and my work as part of the Royal College, and then also some sort of management and sort of strategic sort of work. So I think you need that variety as a consultant. If I was just seeing patients all day, every day, I think you might start to get a bit burnt out and exhausted by that. But equally, if I was just sitting in management meetings all day, I would definitely find that boring and understimulating. And so sometimes if I've had a difficult day of meetings and the next day I see patients, I think, oh, brilliant, this is why I do this. I'm, seeing patients today. And, it's lovely to actually be able to talk to somebody about what's going on and offer some treatment. And that's really satisfying. And equally, if I've had really busy days of seeing lots and lots of patients, I think, oh, brilliant, I get to go and do some teaching tomorrow and speak to all these really keen students. And, that's a really different type of work and a different thing to be doing. So I really like the variety. And I think having a job that allows you to do all those different things within it is really important and really helpful for me.